You can get us. Thank you, Nasra. So thank you all for joining us. I know a number of you were part of our regional session earlier today, so welcome back. We'll try not to duplicate too much of the material. We will do some of the same level setting that we do on all of these programs, but we'll try to get through them quickly, really allowing time for the CBOs here from Shasta and Sonoma to be able to speak with our friends at Partnership. HealthPlan in particular, just the background on the folks that are bringing you this programming. My name is Sadhana Devaraja. I'm Managing Director at HealthBegins. We're a small mission-driven consulting firm based in California. We're the project lead here, and we are joined by Aurrera Health Group, who is a project partner on this project, also a mission-driven consulting firm based in Sacramento. This work is generously funded by the California Healthcare Foundation, without which this wouldn't be possible. So really thanks to them for helping us bring this TA provision to you. As always, we have these key terms just to make sure folks know the acronyms that we'll be throwing about during today's session. By now, this should all be familiar for folks, so we don't spend too much time here. By the end of the session, attendees will be able to describe goals for this partnership network, really understand who your key contacts are at your partner MCP. In this case, it is Partnership Health Plan for these two counties. So knowing who the folks are at the plan, and then describing key contracting considerations for CBOs in the context of partnering with your plans. And it's really taking the frame of the community support, formerly ILOS services. So following from those objectives, this is our agenda for today. We'll just do this kind of background and level setting. Do want to do some introductions, especially of our plan contacts, as well as for the CBOs in the room, for each of you together in this room. We will go through some key contracting considerations led by our friends at Transform Health, who are our implementation partners on this project. And then we'll go through some partnership health plan slides as well. Before opening it up for Q&A and next steps, we have this section for Q&A at the end. We really encourage folks to chat throughout, to ask questions throughout, unmute and ask questions. So while we do have that time reserved at the end, we want to make sure that you feel comfortable asking questions throughout, because that's really what adds to the richness of these sessions. I know most folks here have been in our sessions before, so you probably know that the background to this project is we're really trying to address the lack of coordinated CBO support and infrastructure to pursue managed care plan CBO partnerships. And to that end, and the stakeholder feedback that we had run throughout the earliest part of the year, we've landed on these learning sessions that are happening in pretty quick succession through November and December this year to help partnership development alongside the rollout of ECM and community supports. Today's is the first of 2 county-based sessions for Shasta and Sonoma as part of this work. As I mentioned, folks here might have joined other calls that have taken place before this, either a statewide session that's been open to all CBOs across the state, might have been in the regional sessions. We've hosted 2 of those. The second one was this morning, as I mentioned. And so this is the first of the county-based ones that's part of this work. And those are the 4 counties that are part of this kind of initial effort: San Joaquin, Shasta, Sonoma, and Stanislaus. Just as background. And I apologize, I'm going through these quickly because I'm just looking at the names here. I think most folks have been in at least one of our sessions before, so I've seen this before. But if there's anything that you do have questions on, feel free to put it in chat, address it to us, and we can address it more clearly or with more time. But our goals are to, first of all, to support CBOs that offer services with high potential value for CalAIM. And so we're really helping CBOs describe essential components of program, assess your strengths, develop knowledge and skills related to this, strengthen the relationships with managed care plans, and be able to draft a plan that your organization can take to develop or strengthen contracting relationships. So through these TA sessions, hopefully piece together a plan for you all. We do want to make it clear and kind of stay on this for a second that our goal is to, really improve the CBO readiness in this regard. So we know that there are a lot of county participants in these sessions, and of course, in the ecosystem that are crucial to this work. The TA provision is really directed towards the CBOs. There are goals, of course, related to how we're working with managed care plans as well, who have been really helpful in helping design these sessions and present on these sessions and participate in these sessions. And so to support managed care plans, we're hoping that these sessions will help save some time as they're seeking to assess readiness themselves of CBOs that they're working with. Some of the CBOs that are included in these sessions don't have those relationships yet. So really developing and strengthening those relationships and define, what capacity could be with these kind of new CBOs that are new to the managed care plan CBOs that might be participating in these sessions, support incentive performance measure goals as we go through these sessions and as the kind of ecosystem blooms for the plans, and to educate a large number of CBOs in these two counties, in this case, Shasta and Sonoma, about, the basics of CalAIM requirements so that CBOs are able to kind of self-select and decide if this is something they want to pursue. And that's something that would be of value to the plans. So assumptions about this session's audience, we're assuming that everyone here is, either representing CBOs serving Shasta and or Sonoma counties, or interested in planning to provide community supports through CalAIM. I will say we're also assuming that there are some counties as well, county representatives in here as well. But really the targeted learners here are those CBOs that you're familiar with CalAIM and community supports, at least at a high level, and that you're interested in partnering and building or strengthening relationships with your managed care plan. So as we go into that, and I know I went at a fast clip there, so hope that wasn't, that was like the appropriate speed for your familiarity with those kind of intro slides, but wanted to get a sense for, in today's session, which of the following community supports is your CBO hoping to provide? And if I could ask Nasra to launch that poll, thank you so much. That should pop up on your screen there. And our poll questions today have kind of become our standard ones. We've been able to see how they've shifted as the sessions have been shifting. So it's really helpful to do this as a gauge to know who's in the room. I'll give it a couple more seconds here because it looks like folks are still filling in. And then I'll just do a countdown here from 5, 4, 3, 2, 1. And so you should be able to see the results on your screen. This is what we've seen in a lot of sessions, that there is a majority of folks who are interested in those housing related or, homeless prevention related community supports with kind of medically tailored meals and recuperative care following close behind. And then there's kind of a spread of the other ones as well. So this is helpful. Thank you for that. I can stop sharing that poll. And then the other thing that's helpful for us as we talk through this is, how far along are you in the contracting process with a managed care plan? And so if we could launch that poll. And I see, Des, your question in the chat. There will be different content here from the 10 a.m. meeting. We'll be sharing some of the key contracting considerations, as I mentioned, presented by our friends at Transform Health, that will be taking a different lens in the provider requirements that we talked about this morning. So that will be different, as well as a presentation from Partnership Health Plan. So I will leave it up for just a little bit longer. And I know these polls and the kind of the intro slides are the same, so apologies for that, but thank you for asking that question. There are a number of folks from the morning session here. And I'll close this out in 5, 4, 3, 2, 1. And so we see here that, there are a number of folks who have not started or have decided against contracting with plans. There are folks kind of further along as well, reviewing contracts or in contract negotiations. I do want to pause here and see if folks could, in chat, let us know if there are specific questions kind of based on your stage and where you are in the contracting process. If there are questions that you're hoping will get answered through today's session. So, want to make sure that the content today is, we'll be able to navigate it to your questions. And so, Nancy, the state session, there will be a little bit of overlap on the key contracting considerations slides. So there'll be about 4 slides that will be duplicated from the state session, but the rest of the content will be different. So I'll keep going for a second here, but if folks do want to chime in with like the questions that you're hoping will be asked, especially as folks are asking, thank you, Pamela, detailed information regarding the referral process. So we'll keep that in our back pocket as we go through our presentations today. And thank you, Danielle, for sharing that resource. But really, encourage, Pamela's modeling here of adding in what specific questions you're hoping to get out of this session today. So we make sure that our presenters and we are all able to get to your questions based on, where you are in your contracting and where your knowledge gaps might be. So I want to move ahead to the managed care plan contacts in at Partnership Health Plan. And so I'll pause here and let Partnership Health Plan folks, introduce yourselves, let everyone in the room know who you are, your role, and love that you added your resources already in the chat, Danielle. So any way that you're trying to support today would be helpful to share.
Sure, I'll start off. This is Amy Turnipseed. I'm the Chief Strategy and Government Affairs Officer at Partnership, and I will turn it over to Deb.
I'm Debbie McAllister. I am the Associate Director of Strategies, currently all things CalAIM's Community Supports. Danielle.
Hi, good afternoon, everyone. My name is Danielle Biasotti, and I am the Senior Project Manager here at Partnership Health Plan, and I'm helping support all things enhanced care management, ECM, and Deb and I are working side by side. Pass it over to Lisa.
Good afternoon, everybody. I'm Lisa O'Connell. I'm the Senior Manager of Provider Credentialing and Network Education.
Great. Is that the whole team, Amy? Did I miss anyone? Okay, that's great. We're so excited for all of you to join us today and to be able to jump in and answer questions as appropriate. I know, we're already seeing some specific questions on rates, things like that might be appropriate for one-on-one. So we're also going to ask folks to share their contact information so we're able to address questions in like the appropriate venues. So try to answer as many questions as we can as a group here, and then also reserve some of these questions that'll come up in chat for one-on-one conversations I know, Danielle, you put this email in the chat, but for these two counties here today, it's the same email because partnership is serving both counties here. So just want to make sure folks have that as we move ahead. And so we'll be relying on, the DHCS standard terms and conditions. We've been sharing this in a number of our sessions. And the three that we'll be focusing on today is delivery of community supports, data sharing to support community supports, and quality and oversight. And before we get to that presentation, we'll kind of launch our last poll here. So that we know, we got the stage of your contracting, but also wondering how many different community support contracts are you anticipating engaging in the next year, just to kind of level set and prep as we get our presenter to the stage here. And so I'll close this one out pretty soon. And so with about a third of folks, so we got some more coming in. Give it just 5 seconds here to close this out. 5, 4, 3, 2, 1, we'll close it. It looks like a number of folks are either kind of in the don't know, still unsure about how many contracts you'll be pursuing in the next year, with the next highest being 1 contract, possibly 2 in this group. That's super helpful. Thank you so much for pulling that together. So with that, I will ask Lisa Chan-Sawin to come to the stage. Transform Health is an implementation partner of ours, and love the delivery of these slides, Lisa, that you've been able to present on key contracting considerations and really technical advice here. And so just encourage folks to continue asking your questions in the chat as Lisa is presenting, and we can get to it in turn. So Lisa, if I could turn it over to you.
Hi, can everybody hear me clearly?
I can hear you.
Thank you. Well, it's really lovely to be here with you all today. My name is Lisa Chan-Sawin. I'm the CEO and founder of Transform Health. We're a national women minority-owned mission-driven consulting firm working in the systems transformation space, and most recently have been working in Sacramento County, supporting the city of Sacramento, running their Whole Person Care pilot. And as a part of that work, we've been providing some of the ECM community support transitions to our local providers. And so we're really excited to be here today to talk about some of the key contracting considerations. We're going to start with the standard terms and conditions and drill down. So it's a small enough group, as Sadhana mentioned, we welcome all questions. There are no bad questions, so please ask us your questions, and there'll be some that we can answer and some that you'll want to have direct one-on-one conversations with your health plan partners, and so we'll note those as well. But if you have a question, chances are somebody else has a similar question, so don't be shy about asking any questions that you have. So with that, why don't we go ahead and get started? So let's go to the next slide, please. Great. So we wanted to start the discussion and really unpack what the DHCS standard terms and conditions mean and how they might translate into the managed care plan contracts for community supports. And how you might think about what the programming considerations are in relation to those terms and conditions. The reason why there are these standard terms and conditions is because the state is setting a core set of requirements. And so these are all requirements that all community support programs across the state must adhere to. And so one way to think about these standard terms and conditions is it's really setting the floor for the way CS should be administered across the state. And so, what the way they relate to the managed care plan contracts here is all of these standard terms and conditions are required to be in the managed care plan contracts, and there may be some additional requirements spelled out as well in the plan contract. So the DHCS standard term sets the floor, and then there can be additional variation above that. So you'll want to understand and know what those standard terms and conditions are, because those are the expectations of the state. And what we're going to do is we're going to walk through them and talk about what some of the programmatic considerations are in relation to each of those provisions. Next slide, please. Great. So we'll start with the delivery requirements. These are the provisions that you want to consider and think through how it might impact your current programming, if you need to make revisions or add new elements to your programming. These will give you some indication. So, the first one is fairly general. The community support providers are expected to deliver the contracted community support services in accordance with the state's service definitions and requirements. These are laid out in your contract and in the program guides. So the way to think about this is the state has issued the standard terms and conditions and a program guide that the plans can use, and then plans are looking at that and adding upon their own. So you want to know what's in the states, but also more importantly, the way you're expected to provide services in a local area is going to be spelled out in your plan specific contract, as well in the plan program guides. So the service definitions and requirements will be spelled out there. You want to pay attention to that. In addition, community support providers are expected to maintain staffing that will allow for timely, high quality services to be delivered as contracted. And so you want to think through and see if there are any additional staffing parameters within your plan contract, and have conversations with your plan partners about what that means to them. Is there a specific staffing ratio? Are there certain types of trainings that are minimum qualifications, certifications that your plan partner is expecting from your staff? And so, you'll want to understand what those staffing requirements are, and they may differ plan to plan. And then when we think about the key body of services, community support providers are expected to be able to act and accept referrals from the plans for authorized community supports, unless the plan has made an arrangement with you where you as a community support provider can have a predetermined capacity and can do some of referrals and approvals on your own. That's still fairly rare. We're not seeing a lot of that across the state, but you'll want to think about, do you have the internal systems that will allow you to accept referrals? And also to really understand what is the process by which your health plan is going to make referrals to you? What systems are they using? And how do you interface with those systems? Is there a workflow that you want to put into place as part of your programming and as you think about how to ramp up your community supports? And that is that referral system is really important, because one of the other expectations is you as a community support provider is expected to be able to conduct outreach to the referred individual as soon as possible and make a best effort to conduct that initial outreach within 24 hours of receiving that referral. And this is a really key point, because oftentimes we're talking about some of the most vulnerable individuals within our communities that are being referred into the program. And so oftentimes, if you don't make an effort quickly, you may lose where that individual's location is especially if they might be homeless or at risk of homelessness. Sometimes their location can change quickly over time. And so the time element here will be important to think through. And community support providers are expected to be responsive to incoming calls, to maintain a phone line, and also to coordinate with other providers touching and serving that same individual client. So you'll want to consider, like, how are you coordinating with other providers on that member's care team? Do you have a process already in place, or do you need to stand up a process? And what does that process look like? Is that in the form of huddles or teamlets with other care teams? Are you reaching into the plan and working with the plan case managers, interfacing with hospital discharge planners? You want to think through what that coordination looks like and what that system looks like, because it can be done as a process in meetings. It could also be done electronically. And so you want to understand and know how other providers in your area are connecting and exchanging information. And the state does have expectations that all CS providers will comply with cultural competency and linguistic requirements and non-discrimination requirements. All of those things, as I mentioned, in association with provision A, will be spelled out in your program guides, which is another reason why you want to pay close attention to those documents. Great. So not seeing any questions, let's move on to the next slide. So some other provisions around the way you deliver services. There is, so federal law requires authorization for data sharing. And so you as a community support providers will be expected to, as the course of doing this work, obtain and document different things for patients. So, you'll need a system to manage that consent, any prior authorizations, and maintain records. And you'll need to think about how that data is stored, shared, and if you have a way of protecting health information. We run into this challenge quite a bit, particularly when we're talking about CBOs who are not clinical providers. The standard for a lot of CBOs is our general privacy and security laws, but healthcare has a higher bar, and in healthcare, we must adhere to HIPAA. And so you want to, as you do this work and are looking at how you're ramping up, you want to think about, do you have a process to manage and receive patient consents and do any authorizations? Does your systems, are they able to store and protect and share this protected health information? And if you have never had to comply with HIPAA, understanding as data flows, what those expectations are going to be very important. So we wanted to flag that for everyone, especially as you think about sort of what's in provision DI. Community support providers are, you're not going to be reimbursed for services that are not authorized by a plan. And yet there is an opportunity for you to conduct in-reach and identify potential individuals. Maybe you're already serving a client and you think they're eligible for this program and could benefit from a community support. So, you'll want to ensure before you begin providing services to that individual that you have the authorizations and you will be able to receive reimbursement for the services you provide. And, you want to think about, do you even have a way to conduct in-reach and identify patients? What is the referral process back to your health plan? And, do you have all the authorizations documented so that you will be able to bill and be reimbursed for those services? So when you take all of these provisions into account, you'll really want to think about, the way you document, the way you take case notes, and how you're storing that information, how you're sharing it with external providers. If you have a way of sharing your care plans, those are some things that you might want to think about and to put into place to support your staff who are doing this work. Okay. All right. Not seeing any questions. So let's talk a bit about data sharing, quality, and oversight. These are things that you want to have and be aware of. So let's talk about data sharing first. Plans the state does expect plans to ensure that you as a community support provider will have access to 3 types of information: demographic and administrative information that helps you understand and confirms that individual that is being referred is appropriate and has been approved for the requested service. They'll also, the state also expects the plans to provide you with the administrative, clinical, and social service information that you might need to effectively provide the requested service. And thirdly, the billing information needed to support your ability to invoice. And so when it comes to sharing these 3 types of data, they may require different processes. And so you want to understand what is your plan's expectation and process for sharing that data. If you're working with more than one plan, you'll want to understand, do their processes differ? And if they do, you'll have to build that into your local programming. Some of these types of data can differ. And so, what comes to mind when we think about some of the administrative, clinical, or social service information that might be helpful to just give you an example, it might be helpful for you if you're a housing provider providing housing navigation services, and you're about to move somebody into a new location, understanding that the timing of when to move that individual, you may want to check in with your ECM provider or the primary care provider to make sure that you're not running into any other timing issues. And I'll give you an example. We had one case where an individual, was slated to be moved, but they were at the same time supposed to get go into surgery. And so that doesn't work, and that's not helpful, right? So it's that coordination point, understanding sort of what else is going on in that individual's life could oftentimes provide a lens around the timing of the services, or when to push in, or what other family members you might be able to engage in support of that individual. And so, oftentimes one of the things we have suggested to providers is, as you think about how to coordinate services, and especially with other providers that are in your community and as part of that patient's care team, is to understand what are the local huddles that are already happening on behalf of that patient. And is there a way to join them, or can you connect with the care coordinator that can give you insight on what's happening to that individual? So some things to think about. In terms of quality and oversight, the state expects providers to know that the plans are responsible for conducting oversight of the delivery of these types of services. The plans need to do this to ensure the quality of those services and ongoing compliance with all the legal and contractual obligations and the way the state is expecting plans to run this program. So you as a community support provider will be expected to support the plans in reporting, in audits, in corrective action. And so you'll want to consider what are those potential things, have conversations with your local plan partners, and think about whether you have existing systems, processes in place that will support your ability to provide this information when your plan partner comes back and asks you for this. If you don't, what do you need to put in place to ensure that you're capturing this data in support of those activities? And an initial conversation early on to understand what your plan's expectations are will save you a lot of grief later on. When they ask you for this information, going back and getting the data will be a lot harder than capturing this data up front. So just some things we wanted to flag for everybody to really consider and think about as you put together your programs. Let's go to the next slide, please, Sadhana. So those are the standards that the state has set forth, and there are variations on the standard. And so we just wanted to flag a couple of things. This is by no means an exhaustive list, but some things that we're hearing from CBOs and providers from across the state that are popping up. So, you want to pay, I mentioned staffing ratios and other staffing requirements. What are the training, certification, or licensure expectations? And what are the types of staff that are providing the services? Do you need to adhere to a staff to patient ratio during the provision of those services? Also, if you're working with more than one plan in an area, you'll want to pay attention to the payment model. Some of the things we're hearing are different plans are for the exact same service, potentially instituting a different payment model. So you'll need to know how that payment model works. Is it a fee-for-service model where you're going to be paid every time you provide a service? Or are you being paid on a per diem, a case rate? Or are you being paid a thought monthly rate per patient, regardless of the resource utilization for that patient? In healthcare terms, we call that a per member per month, or a PMPM, and that's a flat rate that you're going to be paid, and you're going to be expected to provide and cover a broad range of services for those individuals under a PMPM. So you really want to understand and know how you're going to be paid for the various services and what the payment model is. If you're working with more than one plan and both plans are using different payment models, you'll need to take that into account as part of your budgeting and staffing. All right. Some other things you want to think through are assignment of patients. You want to know, how do you receive, beyond knowing how you receive referrals, you'll want to consider and know how many patients can your organization expect to be assigned. And if you're currently already providing services to existing clients through whole person care and those individuals are being shifted, you'll want to know, are you going to be receiving those individuals as part of your assignment come the January? How long you might be expected to serve each patient, and what is the anticipated length of service? Is it 6 months? Is it 9 months for individual? It all varies depending on the service. So you'll want to ask these questions and understand how patients will be assigned, how long you'll have them, and what types of services, in what way are you expected to provide services. So some things to think about as you're building your program. And we've already talked about receiving and providing referrals, understanding what process, the frequency that your organization may be referred patients will be important as you're thinking about budgeting. And if you have a potentially eligible patient, how do you provide a referral back to the plan, and how do you understand that that individual has been authorized and ready to go for a community support? Those processes are local, and you'll want to understand your local nuance. And lastly, ensuring that you have the capability for data sharing, invoicing, and reporting, ensuring that you have your local systems in place to be able to do this on a regular basis. Understanding, some plans are requiring providers to use a certain platform Some plans are, leaving it open for providers to choose what platform and the mechanism by which they are sharing data. And so you'll want to understand the nuance specific to each of the plan contracts you're engaging in. I'm just checking the questions, and it looks like there are some specific questions to partnership. So I know we have a subsequent presentation from Partnership Health Plan, and so I will leave those questions to them, but just wanted to take a temperature check to see if there are any other questions or thoughts around contracting and what to consider as you're building out your programs for the new year.
Thank you so much, Lisa. And maybe I'll start with, Pamela, I know you put in one of the first questions requesting more detailed information regarding referrals. And so just wondering if that's something that we could answer here, if you felt like it was covered in this piece of the presentation, or if you could just unmute and give more color to your request there.
Yeah, sure. Thank you. Yeah, just with regards to, we currently are under contract with PHC for our Nightingale services, which is respite for individuals experiencing homelessness discharged from hospital, and are exploring providing some homeless services related to that, as we are a homeless service provider. And we're considering providing those services for those individuals that are directly discharged to Nightingale, but broader would be interested in exploring, kind of the internal referral process, or how would it happen that, and I know there are other, of our homeless service providers on the call from Sonoma County, how would it happen that you would make those referrals to us for an individual experiencing homelessness for services? What would that look like outside of our Nightingale process?
Pamela, or I will turn it over to Deb to answer that.
Hi, Pamela. We actually set up a call with you for later this week so that we can discuss some of this. Referrals are going to come from the social workers at the hospital, or the discharge planners at the hospital, or they could come from a PCP, or it could be that an ECM provider refers the patient for shelter or for another community support. To be 110% honest, which is sometimes a good thing, and sometimes people are like, don't tell me all that. Until we jump into January 2021, we're not 100% sure of all the processes. Right. So we're going to roll with it and know that the services we currently are utilizing, we want to continue to utilize, but we also want to prevent additional social determinants of health by affording other opportunities for CBO-based participants, as well as the counties, to get more members that have medical compromising situations off of the streets and into safe shelter and to a better continuum. So some of your specific questions, we would have to put in a probably do a case-by-case basis, because each and every situation is unique. Right. Okay. And yes, and thank you for setting up that meeting on Friday. That'll be really helpful. And, we'll share what we learned with our fellow providers. And I see Jules weighing in here too. So that's great. I think it'll really help our continuum of care overall. Thank you. Yes. Thank you.
Thanks for that question, Pamela, and for those responses, Deb. And so I think, a number of these questions may be specific to partnership, and I know that partnership, your presentation is up next, so maybe we'll go right into that one. I thank you, Lisa, so much for that presentation and level setting of the standard terms and conditions related to what CBO should be considering as you're engaging in these contracts, just in terms of workflow and in terms of what capacity is. I think that those are really helpful level setting questions, and we've heard as much. But I will now share screen with some of the more nitty gritty aspects of contracting for partnership to lead us through that. I'm not sure if Deb, will you be, should I turn it over?
Yes, I will. Thank you.
Okay.
So some of you I see have probably heard this before, but we're just reiterating some things, and we're just trying to, poor Catherine, I think you've listened to this 5, 6, 7 times, but I'll try to put a different twist on it this time. So community supports, which used to be in lieu of services, which we liked the name much better because it made more sense to me, but to a member, I guess community supports is easier for them to understand. Next slide, please.
Oops. Sorry, my mouse.
That's okay.
Does that work?
Well
Okay.
done.
There you go.
The community supports in lieu of services implementation timeline for partnership is services will go live in PHC network in 2 phases. The first phase is going to be our current whole person care program counties, and the second phase is counties without existing whole person care. So phase 1, January 1st, 2022 is Marin, Napa, Mendocino, Shasta, and Sonoma. In phase 2, July 1st, 2022 are our remaining counties: Solano, Lake, Yolo, Humboldt, Del Norte, Trinity, Siskiyou, Modoc, and Lassen. Next slide, please. Community supports partnership will be providing the following 6 community supports to eligible members beginning January 1st, 2022. We may add or remove community supports at defined intervals, which is every 6 months, for an addition and annually for a removal. We don't plan on removing any, and we're hoping to add more depending on what we're able to safely and equitably provide for our membership across our counties. So the first 6 we're going to go live with, we're going live with 8, but because of difficulty procuring participants to do the providers, we have had to pull back, and now we're just going live with 6. Housing transition and navigation services, housing deposits, housing tenancy and sustainability, short-term post-hospitalization housing, recuperative care, which is medical respite, and medically tailored meals or medically supported foods. The following services will be offered as of January 1st, 2023, and that will be the respite services and the personal care and homemaker services. Next slide, please. Assessments and contracting. Next slide, please. Assessments, all community support providers or vendors will complete it and submit a readiness assessment. This helps you as well as us to identify what services you're able to provide, how many people you would be able to provide it to, what areas or counties you'll be able to provide in, as well as what resources you currently have, et cetera, et cetera. So to request an assessment, all you have to do is email our wonderful little CalAIM at partnershiphp.org website. Or not website, that's an email. A decision will be, PHC will review the assessment once it's received. It's a 1-page, 1.5 pages, I think, for you to submit. A decision will be made and providers will be notified via letter. If the provider or vendor is approved, the vendor will receive a letter of congratulations and will be required to submit paperwork. Enhanced care management and community supports will be separate standalone agreements. The reason is because, of course, they offer totally different supports and services, and the provider pool is quite different. Next slide, please. For contracting, what is needed: community supports provider form and a new vendor setup form. These will be provided by PHC once you have submitted your assessment and you get your letter saying, yippee, join us. Everyone will need to have a contract to be able to be a community supports provider. A W-9 will be required, a current business license, certification of insurance for your company, and a department check which PHC will complete. And upon receipt of completed paperwork, PHC will send a contract. We're trying to make the contract very benign, specific enough to make sure that we're able to cover all of the things that DHCS has requested, but also trying to make sure that it is consistent across the board for all of our providers. Next slide, please. Training. Next slide, please. Training, provider education and onboarding webinars. The first two are going to be December 2nd and December 8th. Both webinars will cover the same material and will be recorded. Providers need only attend one webinar. You can email the CalAIM at partnershiphp.org for registration information. Provider roundtables will start beginning January of 2022. And we're not 100% sure yet if we're going to do that by community support type, or if it's going to be by county or both, or everyone come on in and we'll have a big round table. But the round tables will be so that we can answer any questions, discuss any situations that have arisen, or things that that people have concerns or want to make suggestions on. PHC CalAIM webpage is here on the screen, and we'll also put it in the chat box. DHCS, ECM, and Community Support's webpage is also here. These are valuable web pages because they list everything from when this, I think the inception first started. But as we go month to month, any of our trainings, any of our information pamphlets, the FAQs are all listed on our website. For additional questions, you can just send an email to CalAIM at partnershiphp.org. Next slide, please. Questions?
Thanks, Deb. And so I'm wondering, we had a couple of questions come in earlier. So regarding the assessment tool, you gave the email address there that folks should email. And then there's a question on whether CBOs are required to utilize, implement collective medical. I don't know if that's something.
No, they're not required.
Yeah, so collective medical, many of the folks on this, it's our platform for information sharing that we tend to use with community supports, but more in particular ECM providers. So I don't know, Danielle, if you want to give an update on collective medical and where we're at with that.
Absolutely, I can give an update on that. So as Amy indicated, it is our data sharing and information exchange platform. And as you heard today and are aware, under CalAIM, ECM, there's a data sharing component where we need to exchange information. Really the goal is to share information for between our ECM providers, the health plan partnership, and the members care team to improve patient care. And so some of the functions that we're working and testing on with collective medical currently are the release of information to any kind of care plans or attachments, uploading those so that they can be exchanged between partnership and the provider. Also transparency around hospital utilization and seeing that data come in to see if a member was, went into the ER or even admitted, so that we're sharing that information for the better of that particular enrollee or member. And then also the big part for ECM is assigning our members to our ECM providers. So that's going to be one of the tools that we use in order to share that information and exchange data.
Oh, no, Danielle, thank you so much for that. And I was wondering, hi everybody, appreciate your work with Sadhana and the rest of the HealthBegins team. I wanted to elevate a couple of other questions that are in the chat. Catherine's question about any estimates for member or service volumes that you expect to cover in each county over the next year. And I imagine that's probably, imagine Catherine and for others, it's probably specific if there's information on member service volumes, even for specific community support services, that might be particularly helpful.
And I think that goes to the question too about a budget model for reimbursements, and it ties to the question of staffing and our ability to respond. So we're all in a little bit of limbo of what to expect and what we're building for. And then there's that question of risk management, right? Like, I don't want to be behind the curve, but I also don't want to be too ahead of the curve in terms of costs.
Understood. So I'll take a crack at this and then let our SMEs, but in terms of the estimates of services volumes, we're taking our initial projections based off those transitioning from the whole person care program to ECM/ILOS services. And we've been working with the county partners in those 5 counties to identify members currently receiving services. A majority will receive ECM, but also there are some in the population that have been identified for receiving some of the community supports. So we know that that's going to be our baseline of information. We know day one that we're going to be responsible for providing those community supports. And we can get those numbers, at least at an aggregate by county, what we're looking at for those who will be eligible for ECM and community supports. Now to the follow-up, well, who comes in after? That's the big question we're all trying to prepare for is the expectation of referrals from those outside of the whole person care program. And we're trying to do our best to understand that. And to be honest, partnership, we don't have a good estimate. We're basing our initial capacity estimates and our contracting needs initially off the whole person care population transitioning. To the point too about budget model and reimbursement, I think it ties to the rates. Our ILOS services or our community supports program, we're paying fee for service and our pricing is based off the DHCS pricing guide. So I think Sadhana and Rishi, you guys have shared that with the group, kind of what DHCS has come up with a range appropriate based on Medi-Cal rate development for each of the community supports. So that's what partnership is using to inform rates. But we're happy to have kind of individual conversations about those rates with providers.
That's great. Thanks, Amy. And just a quick note on that, we will be talking about that next, that ILOS pricing guide, and we'll share it with this group right after.
This is Chuck from COTS. Is there an available budget template that as we build our budget model that we can use, for example, if we want to provide, transition navigation services or housing deposits or housing tenancy services, just so we know what the reimbursement rate is or fee for service and, a number of visits or encounters that were allowed?
So partnership itself, we haven't created a budget template because we have so many different types of organizations providing services. And I think some of the staffing is different. We're happy to share the rate. And again, depending on the organization and the size, that's going to inform how you budget, how many members you can serve based on the rates that we are suggesting in our negotiation process. So we as partnership aren't able to give you a budget template because for us, the challenge is we have so many different types of providers that want to provide ECM and community supports. It's just not feasible, nor do we know your business operations in terms of staffing and FTE costs and all those things that come into play. So, but we're happy to share the rate information. And as Sadhana said, I think that's going to be coming up later in the presentation.
Thanks, Amy.
And then I did see a question, are we looking for CBOs to provide ECM or just community supports? The answer is both. So we do have 2 different assessments, as Deb referred to. We have an ECM and a community supports assessment. So if you're interested in providing both, please email our CalAIM inbox, fill out both assessments, and then you'll be working to note, as was already said, we'll have 2 separate agreements with you. One would be for ECM and one would be for community supports. And to note, I think I saw a question on the chat. If you're already a contracted provider with partnership, we will be having a separate agreement with you for either ECM and or community supports. Sana, do you want me to just jump in on the chat?
Yeah,
if there's
feel
more
free
question?
to jump in. Yeah,
Okay.
I just saw it. Sorry, I was responding with a budget tool from the Corporation for Supportive Housing that might be helpful to the previous question that was.
And I think this was just a partnership. We have one for community supports, one contract template. And so we're having entities check off if they want to provide just one or multiple community supports. If we add new ones, would we need to adjust the contract? Yes. In terms of if we would like you to mark everything you're interested in offering to avoid going back, but if we didn't check it off, we could quickly amend the contract to add what you want to offer. That also includes if you are an entity that it wants to serve not only a whole person care county phase 1, we'd like for you to identify if you want to provide additional county services, just so we have the landscape for our contracting. So hopefully that answers your question, Josette.
And I also welcome Josette if you want to unmute and ask, you know, if there was more color you'd like to add to your question. Feel free to do so.
Can you hear me?
Yes.
Yeah, I just want to, we're looking over the contract right now, and we've sent in a few questions, areas of concern. And then you mentioned that you might be adjusting what services you might allow us to do every 6 months. And I was just curious about how that might affect a contract, which has everything in writing. So it looks like we'll have to adjust as we move along. One of the areas we were concerned with, I'm sure you heard in the other meeting, was the 50-day or the 90-day limitation on housing support and transitional services. And transitional services, navigation services, 90-day restriction. That is a very short time to provide those types of services and have any sort of successful outcome from it. So we were just concerned about, is that a strict limitation? Is that a retar? Have we decided how you want to handle the 90-day restriction you've added?
The 90-day restriction, this is Debbie. The 90-day restriction came from DHCS. It's their guidelines. I know that numerous people have posed to DHCS exactly what you have said, which is that is such a very short amount of time. So I think we started, or maybe it was this morning when I pointed out that every day's a new adventure and we keep changing and hearing different things. So I do know that these concerns, it never hurts to give them to DHCS because like you said, 90 days flies by. And some of our very complex, you don't even have to be very complex. The housing market is such that finding places for someone with multiple issues, mental as well as physical or abuse situations, it takes an army and it takes a long time. So it doesn't hurt to let DHCS know that you have concerns about those things.
Yeah, absolutely. I'm sorry, I wasn't aware that it came from DHCS.
Yeah,
Kind of
we
figured.
didn't make any of these rules. I'll be real honest with you.
You did it all. It's
I
all your
did it,
fault.
yeah, let me take responsibility for every single one.
That's right.
I think Deb makes a good point that partnership, we tried to keep the same criteria. I know different plans have different strategies in terms of their eligibility criteria for community supports, but of the 6 to 8 community supports we picked, our criteria is, our goal is to align with DHCS.
That's good, at least. I mean, that's consistent. That's going to be, it's going to be interesting.
Yeah.
Yeah.
Yeah, so I think, Sana, this was, I know we had a conversation offline. There's so many different funding streams related to housing. This is just one, is the community support, but there's the housing funding through, I think, PATH, and there might be through that home and community-based spending plan. Maybe helpful to get a landscape of all the funding that's out there related to housing and homelessness right now, supported by Medi-Cal, to help tie all the funding streams together.
And also an understanding that it's not just the acuity level of the client, it's the lack of housing availability.
100%.
Reading is starving for apartments and small housing and whatnot. So that makes it extremely difficult to house someone. So anyway, okay, so that was kind of the concern. Yeah, I don't think I have any questions right now. I know how to find you. I have more questions.
Please,
I'm not shy.
Yeah, I appreciate that. Maybe following on that thread of kind of the different funding streams a little bit. I saw a question earlier. I don't know if this was addressed, that came from Nancy about if you have a contract with PHC for a non-CalAIM service, you know, do you need to be certified? You know, what's the process? Is it the same process?
They would need a new contract to be an ECM or community support. So I don't know, certified. I think I would defer to Lisa if they have the W-9 and everything else for contracting on file. That would be helpful. But in terms of for the base agreement, we would need an agreement for ECM and ILOS services. But I don't, Lisa, anything to add in terms of this
No, I didn't know if they
certification
meant
process?
certify or credential, but yes, they would need to fill out the assessment and then go through the contracting process, which is similar. And if you had providers already credentialed with us, it would be, we would just add those. We wouldn't re-credential providers, but the organization we would add the new contract to.
Right. Thank you for that, Lisa. And Nancy, if you want to unmute and kind of follow up with your question, if that answered it, or.
Yeah, I think that answered it. We provide NEMT, so we already have a contract with Partnership. And I was just wondering if we start over, or do we just, you know, get a contract for those particular services? For the new services, what we're interested in is medically appropriate food as well as home modifications. So we need separate contracts for all of that, right?
Well, and you would need a separate contract for community support services. So NEMT is one very uniquely special thing. And then for community supports, you would need to have that assessment and that contract.
Got it. Okay, thank you.
Thank you.
Okay. And I see some kind of continued conversation on that 90 days question and service.
Well, we're all on the same page with that. We don't like it.
I don't know if I've missed any. And then I'm getting another question. I think it's a repeat of whether you're looking for ACM providers in addition to ILOS.
Yeah.
There's yes, and this the TA provision that we're providing is focused on community supports in ILOS, and so that's why the framing of a lot of this is focused there. But that's not you know, the entirety of what Partnership is interested in.
I will plug, we've done some webinars about ECM providers and requirements. So the link Danielle Biasotti put on it, we have recorded webinars about ECM and what we're looking for ECM providers. So that's available on our website as well, if entities do have questions.
That's great. And so maybe before we go to the next kind of section, and I'll cue Rishi you up for the kind of the resources piece of this, but if anyone does have any questions now, Laura's question. So Laura, was there a question I missed?
I assume Laura's comment more about sometimes the conflicting information from DHCS on the criteria. Right. So we can go back and look at that in terms of our criteria.
This is Laura. I guess I was just wondering if maybe there's a more recent guide out, policy guide. The one we have is dated in September. So.
No, that's the most recent guide.
Because it
that's
does.
The only one.
It says in there that the services are as long as necessary. So we were just a little confused. That's all.
We can follow up offline with that for all the services versus the 9-day, because I know it's sometimes like the housing deposits, it's a one-time only. So that's something too we can take back.
That sounds great. Thanks so much, folks. So I'll cue us up to the, can you still see my screen here? All right, so thanks, Deb, for leading that presentation. And so we wanted to just share a few slides of resources, you know, before we closed out for today. And I'm wondering if Rishi, you could kind of take the baton and share these slides.
Yeah, thanks, Alvin. I'll be really brief here because I think that what we've been doing for the past 20 minutes, I think has been probably the most valuable, I know, for the CBOs. And again, really want to express my gratitude to our friends from Partnership who are here to answer those questions. So I'll be brief and really pick up on, Amy, a point you made about the pricing guidance. We included this in the chat. We'll put it in again, so you don't have to scroll back in there. But as Amy mentioned earlier, we really encourage all the community-based organizations on the line today to read the non-binding, I want to reemphasize that point, non-binding pricing guidance from DHCS. It's a very long document. If you look at page 12 and beyond, you'll see specific recommendations, including midpoint price ranges for service rates. You'll see cost drivers and then assumptions for each of the community support services. We know that there are critiques of the methodology and the ways in which these midpoint price ranges were developed by DHCS, and we've heard those in other TA sessions and one-on-one dialogues with many community-based organizations in particular. And having said that, we know that there is some language very specifically within the pricing guidance that makes clear that, I'll just read to you some of the salient points here, that the pricing guidance is meant to be a starting point, or can be a starting point for discussions internally as well as negotiations between community-based organizations and plans. And so again, this resource is a very important document and resource that we elevated earlier today on a regional session and want to bring up again in the context of what several of you were discussing in the chat and the discussion. In that pricing guidance, you'll see that the information about program structure, there's an acknowledgement that program structure, staffing ratios, volume, as I think several of you mentioned, geography, and also payment models. For example, payment models like bundle payments or per person per month, cost-based reimbursement models or fee-for-service models. The payment models can also be a very important variable along with the others to determine the pricing that you'll pursue. In that pricing guidance, they also provide examples of how those factors like caseload variation, as you can see on the right, can modify or change the rates that a CBO might seek in negotiations, again, with your plan partner, in this case, Partnership. So it's a really helpful resource. As we go to the next slide here, we wanted to highlight that in particular against a number of other resources that I think Lisa and others had alluded to earlier. Clearly, DHCS has the resources, and many, including on the plan side, are tracking to the standard terms and conditions, as well as the resources and the guidance that DHCS has provided. You'll see here the available policy decisions and links. We'll send these out after this meeting today, so you all have access to these links. The next slide. There are a variety of webinars beyond, obviously, today's meeting. DHCS itself has a variety of webinars that could be helpful if you're earlier in the process. And of course, as Amy and Deb and Danielle and Lisa have mentioned, there are wonderful resources on Partnership's website as well for information, including links to webinars. And so again, we'll make that available, and if we can, maybe copy and paste that and put it into the chat today. That'd be great. As we go to the next slide here, I think the reason I went through that relatively quickly is only because there's a lot of information in the pricing guidance, but I think the place we were in just before I took the baton was in a good spot to start getting even more questions surfacing, especially around the questions that the pricing guidance document kind of addresses. So I'll pause here and see if there's any questions that people have, especially around payments or the information in the pricing guidance, and invite those who've had a chance to already look at the pricing guidance and on the CBO side and have questions about it or want to raise any questions based on that for our plan partners here, please do so. It might be helpful. I'm happy to do a quick screen share, just if you just to show an example of what I was mentioning on page 12, starting on page 12, the information in terms of the pricing approach, service rate, cost drivers, and assumptions for each of the community support services again, starting on page 12 of this pricing guidance that you'll find here. So again, you'll see specific dollar figures with the associated assumptions about the midpoint price ranges as well as service rates that are in here. And I really just want to reiterate that this is meant to be information to help support the internal discussions within each CBO to think about what rates you need and then engage in conversations, specific one-on-one conversations with the plans to be able to negotiate the rates that you need to be able to cover your costs. Are you, Amy and friends of the partnership side, as our friends on the CBO side are thinking about the pricing guidance or any other questions? Is there anything you wanted to kind of emphasize, Amy, in particular, because you mentioned the pricing guidance as a helpful resource? How have you seen that? How is that informed, I guess, some of the dialogues, the one-on-one conversations that you're all having in partnership between a partnership and the CBOs?
I'll defer to Deb on the one-on-one conversations because she's been our front line in answering questions. But I will say, alluding to Deb's comment, like for partnership, we are not getting any additional funding for the state to provide community supports. We have to show that we are providing these supports in lieu of a Medi-Cal benefit or service. So we have to demonstrate that we are authorizing these services to potentially show cost savings to the Medi-Cal program. So when it comes to these rates, one, that's a challenge that this is what DHCS has provided, and that's what they think the cost of these services are too. But in terms of authorizing the services, we have to show that they are cost effective in terms of other potential spending in the Medi-Cal realm. So just wanted to provide that context. Deb, I don't know if you want to share just some feedback you've heard from providers about the rates from DHCS.
Well, I'm not going to say everybody's jumping up and down for them because we're in the mid-range, which means that we didn't take the low ball and we can't do the high ball. So some people are thrilled that it's more than what they're getting now, if they are getting anything. And so we're just going to have to take it, like we said, one step at a time. You know, you have to look at the per member per month. You have to look at what your capacity is, look at what is actually included in the services, look at what other services can be brought in on top of or in addition to a service. There may be two services. So that's what I'm working one-on-one with people with different scenarios to identify if there could be more than one community support that a member would have. Again, as Amy said, we don't get any reimbursement for this. So I may not be here next year if I can't prove that I utilize the funds as appropriately as possible. And that's why I'm working with our community partners to make sure that we're all on the same page because we're all in it together.
I think for me, because we're in this conversation with you guys, is to realize like we're at the beginning of a big transformation and we're all like, you know, there's a lot of unknowns here and we're going to have to figure it out as we go.
Right.
And I think we looked at the initial contract as just the starting place, like, and you know, for us, like, I know our cost structure really well, and within a certain framework, the current cost structure works for me. If I'm now having to drive to Napa for a delivery and we're at capacity, that's not going to be the case.
Right.
But my feeling is this is really important work, right? This is what we all want to see happening. And we're all going to have to take some risk and step in and be willing to figure it out together. And then we'll make those adjustments down the road to make sure that everybody is sustainable and taken care of, right? And I understand this, you guys are taking some risk here, right? You don't know what it's going to look like. You don't know where the cost savings are going to come from. And so we all just need to see, like, we're all sharing risk here and we all have to be willing to take a little bit of risk and step into the pool and know that we're all on the same team trying to figure it out.
100%. Thank you.
Really appreciate that point. And I'm wondering, Sadhana, can I take prerogative and raise a follow-up question?
Yeah.
Speaking of risk and models, payment models, right? That I think some had even mentioned in the chat before about as well, like, you know, ways to balance risk across plan and CBOs. I'll share screen and just show something as a reference to the question that I'm going to ask. Again, this is the pricing guidance. If you can see my screen here, you'll see on page 5, in the pricing guidance from DHCS, there's acknowledgement of the use of value-based rather than cost-based payment models. And there's an acknowledgement as you scroll down through it of the fact that whole person care pilots, many of the community supports, as they acknowledge here, the pre-approved community supports were provided as part of whole person care pilots. And they're mentioning that may offer some opportunities or circumstances to adapt or build on existing structures for payments. One of the things that I think that's the reference for the question I'm going to ask you guys is on the plan side first, maybe on the CBO side second, is this point. They acknowledge that historical, even though the whole person care pilots may be a helpful starting point or a structure to kind of build off of to consider payment models in ways that can help navigate and balance risk in the way that Catherine, you brought up. They also acknowledge that some of the costs for the whole person care pilots included what they're calling cost drivers, meaning costs associated with capacity building that may not be appropriate to include in service rates. And they're mentioning that cost drivers may be better addressed outside of the rates used to reimburse for the delivery of that service, such as through funding under the Performance Improvement Incentive Program. And so based on the pricing guidance, I'm also, I think, Amy, you brought up this point earlier about braiding and the fact, for example, for housing supports, there's a number of different funding streams that are out there. I'm wondering if you could just spend a moment on the plan side, at least first, is talking about that performance incentive program, because it may, for some CBOs, they may not be familiar with that, and particularly, the implications of what that means when it comes to the risk that you're taking as a plan and the risk that they need to kind of be aware of on the CBO side.
Yeah, so as part of the state budget approved this year, the state allocated a large pool of money with their calling for the CalAIM incentive program. And so each plan is going to be allocated a certain amount of dollars over the next 3 years to build up the CalAIM program. There's 4 buckets in terms of infrastructure building, ECM capacity building, community supports capacity building, and quality. And so what we're doing at partnership now is looking at where our gaps are, also what we're able to see our capacity needs are based on kind of where we're at with providers and contracting. But that's going to inform how we want to spend those funds to bring up capacity. To your point, Rishi, one's going to be infrastructure. Like it's probably not in the community support rate to have a billing system per se, but we've been allocated some dollars to help CBOs maybe invest in a billing structure. So we're hopefully moving away from an invoicing to more of a claims system for encounters and quality data. But those are some of the costs we know that an organization is going to have that probably will not be reflected in the actual price of the community supports, but that there are funding pools out there. Year 1 of the incentive program is expected to start in early 2022. And what partnership is thinking about is structuring, again, this hasn't been finalized, but somewhat of a grant program where we work with the providers that are interested in providing ECM and in lieu of services, and they tell us what they would use potential funds for to increase their capacity. So to Catherine's point, if she would expand to a different county, what would she need? Would it be an additional FTE, and how many more members could be served by bringing on that FTE or extra cars to buy to deliver meals? And she's not, but there are different streams of funding that the state has created to invest in building capacity and sustainability for the CalAIM program.
Thank you.
Great, Amy. Yeah, and I know we're kind of running low on time, but I saw, Jules, you had your hand up. And so if we could get this in as the last question before we close out.
Thank you. Just a quickie. I work at COTS in Sonoma County. I'm looking at the descriptions of the various things. I'm looking actually on page 17 at short-term post-hospitalization housing, and there's a description of what that is. That's just a description of how you came up with the dollar amount, right? It's not to say that we have to have a facility between 15 and 30 beds and 1 to 10 staffing ratio. I'm just checking to make sure I'm understanding that correctly.
You're correct. Those estimates were made by DHCS when they came up with formulating dollars. So it's an estimate or a thought that you have between this number and this number, and you perform this and this and this. So it's all generalized.
Okay, Deb, thanks. It's not a requirement. It's just that's what those numbers are based on. Okay,
yeah,
that helps me. Thank you.
You're welcome.
That's great. Thanks for that question, Jules. And thank you, Amy and Deb, and Lisa and Danielle for jumping in on all these questions and clarifications. I am going to kind of move us to next steps here with our final minutes, and just invite you all to, reach out to us with any questions or feedback. I know Danielle had earlier put in some of the contact information for our partnership. I don't know if Danielle, you'd be able to put that in again at the end here, so folks will have it at their fingertips as we close out today. And I see a question from Saskia on current gaps that you're looking to fill. I don't know if that's answerable by chat in these last few minutes.
If you want to be an ECM provider in those counties, as well as offering any of the 6 services, that's what we're looking to build capacity for. So Deb, correct me if I'm wrong, but we're looking for any provider willing to provide these programs, because we know there's going to be an increase in interest as these community supports, more people become aware of them.
The more the merrier, we say.
That's great, love that. And so really encouraging folks to use that contact information that Danielle used, put back in chat, to reach out to the Partnership Health Plan folks. We will be hosting a few more sessions here. So we'll have our next statewide session on December 16th. That's actually going to kind of conclude our work here. And in the interim, we'll have one more of these TA sessions for Sonoma and Shasta CBOs. We've been having a pretty open door process in terms of invited CBOs. If you have peer CBOs that you'd like to receive an invitation, please reach out to us at HealthBegins, and we can include them on the invitation list. So with that, thank you to our presenters. I know Lisa had to drop off just a couple of minutes before here, but Transform Health and Lisa Chansaman, thank you for your presentation, as well as our friends at Partnership, and for everybody for being so engaged and putting in questions here. I think this was a really great session, and appreciate your questions, and feel free to keep them coming as we lead up to the December 10th session. Please fill out the survey. It'll help us inform us on what topics that we may need to dive into further during that December 10th session with this group. Thanks all.